I wanted to start with giving you a kind of more of an overview about the research network, the platform that started about 2 years ago that we're part of. We're one of 11 nodes in this platform, and then tell you more about specifically our node, our mTOR node, what we're doing, how that's relevant to you guys, to LAM, and to the other diseases that we're interested in. And then finally, sort of focus a bit more specifically on the work that we're doing and how it's relevant, I think, hopefully to LAM and to LAM patients, and how we might be able to help and progress with the research. So 2 years ago, the MRC, so the Medical Research Council and National Institute of Health Research, who are the big medical funders in the UK, came up with this idea to fund a rare disease platform. So this was a 5-year grant, and it was a lot of money. It's £14 million went into this, so taxpayers' money funding this. And the idea was really to try and pump prime research into rare diseases. And as we've heard just a moment ago, and LAM is a rare disease, but if you may have heard this a few times already, but there are many rare diseases. It depends on how you count them, but there might be about 7,000 rare diseases. And each of those is individually rare. But if you take them in sum, there's about 3 million people in the UK with a rare disease. So there's actually a lot of people affected by rare diseases. So the kind of thought process was, let's not think about them individually, let's think about them as an overall group, and then they're having a real impact on society. So there's about 1 in 17 people in the UK has a rare disease, and most people won't know somebody with LAM, but most people will know somebody with a rare disease, or who's had a rare disease, been affected by a rare disease. And particularly a lot of rare diseases affect children, disproportionately they affect children. So that's, that was the motivation. And the UK is great, it has an amazing track record particularly in the basic science in rare disease. But the idea of this funding was to try and bring people together and really synergize what we already have in the UK. So one of the things that the explicit criteria for the funding this platform that we applied for was that you couldn't apply for research into a single rare disease. So the funders we couldn't have applied to work on just LAM or just another individual disease. They want, because there would need to be 7,000 grants. It's just not going to happen. So the idea was that you would work on some sort of group of diseases. And one of the things that they wanted was that groups of diseases that were connected by the underlying biology, by the underlying mechanisms, the molecules involved. And obviously, like the last 20, 30 years, medical research, basic science research has been hugely successful in understanding the causes of diseases, and particularly genetic diseases. We've been really good at that, identifying genes and finding out what they do and then linking them to diseases. So the group of diseases that I've been interested in TSC and tuberous sclerosis complex for a long time. And we know from research from many groups across the world over the last 20 odd years that these 14 diseases, which we call mTOR diseases, mTOR pathway diseases, all have an underlying common cause. They all have a mechanistic, a common mechanism which links all of them. So that's partly what I'm trying to kind of introduce to you today, is this concept that LAM isn't on its own as sitting out there isolated in an island. It's actually one of this group of diseases. And there's lots of benefits of thinking about LAM as part of this group, and hopefully I'll explain a bit of that. So one of the complexities of thinking about this group of diseases, and TSC kind of encapsulates this, is the different clinical specialities that are required to treat patients with these diseases. So I guess LAM with lung, kidney is, that's part of the story there. But if you look at these diseases as a group, they affect many different tissues, many different organ systems. And that makes it traditionally, with the way that we do clinical medicine across the world, not just in the UK, but everything's very much siloed. So if you have a neurological disease, you go to see the neurologist. You might need neurosurgery. You'll go and see Simon if you have a lung disorder, if you have a respiratory condition. That's great, and you see those people who are the experts. But when you have a disease that affects different systems, then it becomes much more challenging, because you're getting, you're seeing one person one day, another person another day. So part of what we try to do, and we're trying to do, is bring these specialists together to get them to talk to each other and get them to work together and think about the different diseases they're working on and how they're connected and how they might benefit from the dermatologist working with, or at least talking to the neurologist and finding what things they have in common. So I haven't kind of mentioned yet this thing mTOR. I keep talking about it. So some of you might have heard of this, and I'll try to tell you why our grant is called mTOR pathway diseases. And so I said we're one of 11 different nodes. There's other nodes. One's working on cardiac diseases, and there's different groups of diseases. But we wanted to focus on this group that we call mTOR pathway. So it's much more opaque to understand for people who aren't familiar what this is, because we're not doing cardiac diseases or brain diseases. We're doing mTOR pathway. Nobody knows what mTOR is. So why it's important is that these diseases, we know, I won't go into all of the kind of cell biology, but we know that they have this common mechanism that in the cells of the people with this disease, all of these diseases work through a molecule called mTOR. So it's a molecule in your cells, and it's absolutely essential for the normal functioning of your cells. And it's involved in we know it's involved in a wide variety of things now. But one thing it has been known for a long time to do is it regulates the rate at which cells grow and divide. So obviously, if you think that's an important process in lots of places and lots of tissues. And it's also involved in things like sensing the levels of nutrients in your cells. So if you've got like low levels of particular nutrients, TOR it's a pretty clever thing. It can sense that. It can tell. It's like a sensor. So it has really, really important processes just for everybody, not necessarily in disease, but just in a healthy individual. You need this. You absolutely have to have this molecule there. But in this group of diseases, we know that they all share this trait that mTOR has been overactivated. It's working too quickly. It's working too fast. And one of the things that tends to happen is that causes cells to grow and divide more quickly. And the other thing we know about these diseases in common is they all have some sort of cellular overgrowth. So, in LAM and in lungs, there's too many cells growing. In all these other conditions, generally they have things like benign tumours in the brain. So TSC patients will have benign overgrowth in the brain. And that is because of what's happened, that mTOR has gone into overdrive almost. It's been kind of hyperactivated. So that's nice. That's interesting. We can think about these 14 diseases and they all have that in common. But it's really, really helpful when you're thinking about the research side of the diseases, because we know that this is in common. And so what probably a lot of you will be familiar with is that if you have a drug, and we do have a drug that can block the activity of mTOR, these rapamycin type drugs like sirolimus and everolimus, and we know how they work. They work by physically interacting with the mTOR molecule, and blocking it, and that's how they work. It's a molecular process. The drug blocks mTOR activity, so it slows down this hyperactivation of mTOR, stops this kind of overdrive, and so obviously it's great we have that in LAM and in TSC, but part of the logic of what we are doing is that any research that we do on or around mTOR, trying to understand how it works, trying to understand what goes wrong, trying to develop new ways to target it. It might benefit all of these diseases. There's common benefits to actually focusing on the molecule and the molecular mechanisms. We've got a precedent for it already. We have everolimus. We know that works. So at the molecular level, that's what we're trying to do, is understand more about what's going wrong, what's happening around mTOR, what's happening kind of after this mTOR overactivation, what goes on in the cells, what goes wrong. So that's the sort of reason why we have this mTOR pathway name. There is a good reason for it, but as we've found through the work that we've been doing with patient groups, it's hard to bridge that gap with kind of you guys to explain, get into the molecular side of things and get across why that's important. So I probably haven't done it as effectively as I could today, but hopefully it gives you an idea. And we really think there is value in these 14 rare diseases thinking of themselves as part of this group, as part of this sort of umbrella, that they're not alone. And at least at the research level, if we can get people talking, working together, there's real benefits to doing that. So I'll tell you a bit more about our node now. Hopefully you have more of an understanding of why we're doing what we're doing. So our node's based at King's College London, and the people involved are, we have deputy director is a lady called Lara Mann-Ritter, and she leads the TSC clinic at King's College Hospital. And then Deb Powell is professor of paediatric epilepsy, so he sees children with epilepsy as well. He's involved. And then Frances Elmsley is at St George's, and she leads I think it's the biggest TSC clinic in the UK. There's about 15 or so specialist TSC clinics in the UK. So she's a real goldmine, real expert with a long track record of working on TSC, and still very, very motivated to do the research side of things. And then I'll tell you in a moment a lot about what we're doing, but a lot of what we're doing is working with patient organisations, and that's kind of why I'm here today, is to try and get understanding across and provide benefit for us and benefit for the patient organisations, and Charlotte Tye is leading on that. And then we've got a project manager, Sylvine, who's been absolutely a critical part of the work so far, and Layla's a research assistant. So overall, what our mTOR node is doing is that clearly, we're doing research, we're researchers, but a big part of the work is, as I said, to get people together, to get the different clinicians together, to get different doctors together with this in the specialities, and try and get them talking to each other and thinking about how we might improve and further the research. And then the science, we sort of call it them enabling science projects, and I'll tell you a little bit more about those. And as I mentioned, we're doing public patient involvement is a big part of the project as well. So that's kind of overview of what we're doing. Generally, the actual research side is we've got 3 aims. So one of those is to develop a registry, a patient registry, to identify all of the patients in the UK with these 14 rare diseases. So obviously LAM is one of those, and we've had kind of initial discussions with Simon in that direction. But we're actually doing it in a non-traditional way, and I don't know, if any of you have been involved in registries or know about them, but the way that they're generally done is the clinician, the consultant, will recruit the patients to the registry, will invite them to be part of it. You'll kind of consent to being part of the registry, and then they'll collect your clinical information that will be entered, obviously in a confidential way into this registry. So that's great in that, but there are big limitations to that. One of those is the funding. It costs money. You need the resources to develop the registry, and usually, as is most research, it's done in a very short-term way for 2 years, 3 years, if you're lucky, 4 or 5 years. But at the end of that funding, then registries quite often are in a difficult place. They don't have money to keep them going, and that is quite a short-term way of doing it. So we're doing it in quite a different way, and it's through an organisation called the National Disease Registration Service. So the NDRS is part of the NHS. They are funded through the NHS, and they actually have access to the medical records, the NHS records of everyone in the UK, which might be a slightly scary idea. You might not know about it, but it's in. You do know, okay, that's good. So it's a part of the Health and Social Care Act a few years ago. So they have a legal basis for it, and it is an opt-out system. So if you haven't heard of this before and you want to have a look at it in more detail afterwards, it is an opt-out system. You can go on the website and you can opt out of it. But it is an incredible resource. I would strongly urge you not to do that, because there's an enormous amount of information in medical records that can be used in a very positive way. You know, this isn't Big Brother. They're not trying to spy on people. We're trying to use this information to get a much better idea, particularly for rare diseases. So that's one thing we're doing. And then the second aim is much more the sort of, my background is I'm a real molecular cellular researcher. And so we're looking at that sort of the things that I talked about with mTOR, and looking about molecularly what's happening after mTOR gets hyperactivated, and trying to find out more about that using these sort of techniques like phosphoproteomics, which I won't go into. And then we're also developing kind of new cellular models, particularly of TSC, to try and understand in the nerve cells in the brain of patients more about what's going on, and particularly about why a lot of TSC patients don't respond well to anti-epilepsy drugs, which we know a good proportion of TSC patients, their epilepsy is just untreatable. And then the final thing is around diagnostics, that we're trying to find and develop new ways to diagnose some of the diseases which are difficult genetically to diagnose, because the patients don't have a kind of overall mutation in their bodies. They just have it in the parts of the body, I guess a bit like LAM in a way, where there's something going on just in the cells that are affected. So that's the research. I mentioned we're doing work with patient organisations, so this is a key part of the project. And what's nice is we've been able to bring together 9 different charities, patient organisations, including LAM Action, to be part of this kind of mTOR umbrella that we've developed. And the charities have been really fantastic. We've had a couple of workshops working together with them, and yeah, we had an initial meeting, and then we've had an in-person workshop as well, and it's been really fun, really rewarding, and I think in both ways. We've managed to recruit a advisory panel of lay people, of people with lived experience of mTOR pathway diseases, and that's been really good. They started about a year ago now, so we're going to have another round of recruitment. But they've been really helpful, and I think we've got a lot out of it. They've got a lot out of it. We've done things like we've given them, got them involved in ethics applications where we have to apply for ethical approval for the research, and they've helped us with that and given us feedback. And they've even been involved in a review that we published recently, and they actually were co-authors. Their names are on that review, so they're now in the scientific literature as having contributed to that work. And this is just a quote from one of the people on the advisory panel that it gives them a really positive sense of what they're doing is valuable, I think, with a disease, especially with diseases where it's so difficult, where there's no effective treatments. This is something really positive. So yeah, so if you do see an advert coming out and you'd like to be involved, please do apply. We'd love to have you on our advisory panel. This was just, I wanted to share this with you. This is something that came out of the workshop that we did recently, or a while ago now, actually in December, with the patient organisations, and we tried to get people's ideas and thoughts on what's common between these different diseases. So obviously everybody has their own experience, and the diseases have their own kind of complications and symptoms, but what are the common themes? And so maybe some of these things are mean something to you as well. Obviously, financial burdens, practical burdens, the kind of uncertainty. People talked a lot about siblings as well. That was interesting. So unaffected siblings, and how the brother or the sister with the disease, what the impact that has on the family and our lives. So that was really good. I think it's really interesting. We're trying to develop sort of materials to incorporate some of that. So what is specifically about LAM? I think ways in which how we might be contributing and helping towards the people, LAM patients and LAM as a disease. So obviously visibility. This is a major funding investment from the UK government. There's as I said 11 nodes. We're one of them, and there's also what's nice is there's a hub who are funded to kind of help us all synergize and to organize events and networking. So it is a really coordinated effort to try to push forward rare disease research, and the mTOR pathway diseases are a really big part of that. And obviously you hopefully will have some benefits from that work. The shared research goals linking these diseases means that research in one disease, research in one of the other mTOR pathway diseases might benefit LAM patients, might lead to new understanding of what's happening in LAM. And so I think that's something we've really tried to cross-fertilize researchers and clinicians in how they're thinking about the research they're doing. And then I've kind of touched on this already, but obviously drug development. There are some drugs for some of these diseases. There are drugs that are being used in LAM that have come out of the research that weren't just kind of the way that drugs are often developed through serendipity, but they were targeted specifically at the mechanisms involved. But the work that we're doing, I think, is bringing in more interest from pharma and from smaller startup companies. We're working with a startup that came out of Imperial College a few years ago, and they are very much focused on mTOR and trying to develop new drugs that target mTOR and target the pathway, and particularly that don't have some of the side effects that the current drugs have, and are also kind of more effective at some of the neurological problems that patients get, which are much harder for the drugs to access, particularly these rapamycin drugs. They don't cross the blood-brain barrier well, so they don't work as well against the neurological symptoms of these diseases. So I think that's something, it's further down the line, but I think that's coming through. And then finally, the patient registry, that's, I think, something that will be a longer term benefit, having an understanding. I mean, it's crazy at the moment, not even the TSA charity, the charity that supports TSC in the UK, they don't know how many TSC patients there are in the UK. They just don't have a number. It's in the thousands, but they don't know if it's 3,000, 4,000, 10,000. So just that basic fact we don't know about TSC, which is by far the most common disease in the group. I mean, I think you're in a different situation. You have a really nice tight-knit community, but there's just some basic demographics and epidemiology that we don't understand about these diseases and the patients in the UK. We'd really like to know more about. We'd like to know about the kind of medications that people are on, how that's affected by the geography of where they live, and is it different in different parts of the country. And so that the registry that we're developing has the potential to do that we can access all of that information. So I think that's all I wanted to tell you about. It's very brief. If you want more information, there is a web page for the platform. The HTML address is there, but you can just Google RDR UK or Rare Disease Research UK, and then each of the nodes has its own page within that you can click onto, and you can see our page and tells you a bit more about what we're doing. And then, of course, you're free to email. That's my email address, and we have a general node email address, which is there as well. So, very happy. And again, if anybody would like to be involved in any way and potentially be on our advisory panel, please do get in touch. We'd love to hear from you. That's everything. So thank you for listening, and I appreciate your time.
So any questions for Professor Bateman from the floor?
In terms of the patient registry, how does somebody get into it in the first place? And really what I'm saying there is, it's a conversation I had earlier on with somebody where they presented to a GP. GP didn't know what was wrong with them. And so they were dealing with LAM, but the doctor didn't know it, probably because of training or whatever. So I can't put you into the patient registry unless I know you've got the issue or the problem.
Yeah.
So are you working backwards from the patient registry as opposed to forwards?
Yeah, that's a great question. So, I mean, this is the problem with rare diseases, that this sort of diagnostic odyssey, it can take so long to get a diagnosis. So we're doing it in both directions. If you are already diagnosed with one of these diseases, and if there is a diagnostic code associated with that disease, we will be able to identify you through your NHS records, and that's fine, and that works really only for TSC and one or two of the other diseases. It doesn't work for LAM. There's no ICD-10 code. So there's these things called ICD codes, which hospitals use to code diseases, we have them for all the common diseases, but for most rare diseases, there is no ICD code. So you can't just type in that code and identify patients with the disease. And this is a lot of the problem with using patient records, is you can't find the rare disease patients. So what we're doing is working the people that we want to work with, and this is why we've developed this network and done a lot of kind of working with the clinicians, is we're getting the patient identities through the clinics. So we started with TSC, and we've almost done, to be honest now, where we've got all of the TSC clinics to give us their patient identity, just literally like the patient details, the NHS number, names and address. And once we have that information, we can then access their NHS records. Not me, I must really emphasise this. I have no access to NHS records at all. So it can only be people working within the NDRS. So they're already in the NHS. So it's really just people doing it within the NHS. But you can access the records, and now you can actually say, you can put the code on that person on their records and say they now have this disease. And it sounds sort of just an administrative thing, but it's a really big step forward to be able to do that. So it would be the same thing with LAM, that it will really be through Simon. I think Simon's doing that his Life Arc Centre are doing this sort of thing in parallel, where to develop a sort of way of identifying all the patients with the disease.
Yeah, you're right. I mean, I was speaking to your fellow, and she said she had 3,000 patients with tuberous sclerosis, which is a huge thing. I mean,
it's the biggest. Yeah,
it's going to be really useful.
Yeah, well, that's the way. One way we're doing it is to bring the patients to the clinics, but purely for TSC, because there is this code. We've just typed in that code through the NDRS, and 3,000 patients popped up. Which is the biggest published cohort in the literature of TSC patients was something called TOSCA, and it was about 2,200 patients from 31 countries. It took like 5-10 years to get all these patients and put them in this registry. We've just typed in an ICD code into the NHS, and we get 3,000 patients. So that's the power of this sort of approach of doing that. And it's, we can't get necessarily all the information that you might get through other types of registry, but we can get a lot of information from that, and we can get it instantly, because within the UK, we have a unique opportunity that there's 60, 70 million people, and we have a single NHS, which there's a lot of, it's not a perfect system, but in terms of electronic data and medical data, there's nowhere else in the world that has anything close to that. The US states, California, 30 million people, but it's all broken up into the different insurance companies, and it's way too complicated. So we're in the UK has a huge opportunity here to lead in this kind of research. Yes.
Can I just ask a parochial question?
Yeah.
Does that cover Scotland?
Okay, so the devolved nation, yeah, it's a great question. Yeah, so NHS, so the NDRS that we're working currently largely just covers. They can get access to records from the devolved nations, but at the moment the sort of best data we have is just from England. So it's still 50 million people. Yeah, it's 50 million people. So it's yeah. But the devolved nations are trying to develop these sorts of things as well. Yeah.
Just going back to the TSC, because if you've got TSC LAM, which I have,
okay, yeah,
would I be picked up under a TSC code, and then you'd spot that?
So do you see a TSC clinic?
No, I've been diagnosed with the LAM TSC via the LAM.
Okay.
That route.
So we need to talk.
How does it work on coding if you've got a bit each?
So
you'll be coded as having tuberous sclerosis, and so I mean, you've got different approaches, haven't you? You've got one where you look in the clinics at the people who've been diagnosed by the clinicians, and then you've got this other thing where people, not always doctors, code people when they go through their GP or go into hospital, and then you can look people up that way. And I'm guessing what you're going to do is look and see how much overlap.
We're going to match them. Yeah, so we're doing that.
Yeah. So I mean, for LAM, as Joe said, there's no ICD code, so we're looking for people coded with lung cysts and people who've had pneumothorax and all sorts of LAM-related symptoms, people who've had angiomyolipoma, and then we're going to have to look. We've got a research fellow looking through all of these things to try and identify patients with LAM that way, and actually other cystic lung diseases. But yeah, it's a lot harder work if there's not a code. I don't know how many people we're going to end up with.
You might find some LAM people via the TSE code when we.
Definitely, yeah.
One of the things, do they ever answer these codes? Are we ever likely to get one for that?
Yeah, I mean, the American group spent a lot of time getting an ICD-10 code, or might have been 9 at the time. But they're not the same in all different countries, which is something I've only recently discovered, which is a slightly disappointing fact. Yeah, you can. I mean, you could get one. I mean, it might be something useful that LAM Action could perhaps do actually.
From a day-to-day point of view, I mean, I know it was a while ago, but when bird flu was around and there was that vaccine, I rang up the surgery and said, shouldn't I have been called for this? I was told, well, no, you've got nothing. You're not on the list. And I had to argue with the surgery manager, who then referred it up, higher up. Okay. Oh, as a special concession, we'll let you have it.
That's very big of them, isn't it? Absolutely. And actually, LAM's not on any of these, priority lists for different things because. Most of the rare things aren't. I mean, it's a slightly sort of different thing. But I mean, the whole raising awareness rare diseases thing that we were talking about earlier on this morning was, is all pertinent to that really.
So are there other rare diseases who haven't got a code as well? Is that
Yeah. No, it's a thing.
Yeah.
It's not just us.
Yeah, sure.
Funding.
Yeah.
You said you got 14 million, was it? Is that over?
I didn't, but I wish I did. Yeah,
How
but
is that going to last? Is it?
so it's a.
Going to affect any of that?
Is the what?
Is the spending review that's coming up? Is that any of it?
Well, so it's a 5-year funding, 5-year mechanism. It started 2 years ago, so we've got 3 years left. Yeah, so the whole platform has 14 million. We have about 1 million for our node. We've got 3 years to go, but no, funding that's already been awarded, hopefully, fingers crossed, but as long as Trump doesn't come in over here, shouldn't be affected by, going in future things might, but not funding that's already been awarded shouldn't be affected. So.
And you bid again, do you? Someone bids again for more research, or is it?
It's just you're just constantly applying for funding. I mean, the slightly depressing thing about this is, it sounds great and there's all this money awarded, but one of the things which they told us during the application process is this is just the beginning. We want you to build on this and use this to get more grants and to bring more research and more resources in. So we've already been, we have a 1 or 2 other things that have already. Grants that have already been awarded that are associated with our node, and it will hopefully expand. I don't know whether literally the platform will be renewed. That hasn't been mentioned, but there'll be other ways to try and.
But it makes you more competitive just because that structure's there. When you put a grant in, these guys can really deliver. They've got this, they've got that. Everything's in place.
So it gives us a precedent for what we're doing.
Still a non-stop task, though, isn't it?
Isn't it? You do all this work and you've got working to so many years funding, and
Yeah, you have to be slightly crazy to do the job.
I think if if you nail the registry thing though, and that's it, that's got to be a lot of credibility with that, isn't it?
Yeah, I think, well, this is the first time that this approach has been used. So, I mean, we kind of, at least, we've got a really good start with TSC, that we're almost there with identifying the patients, and then it's just kind of starting to actually get the data together and publish the data and show how useful it is and get people interested. And now you have a defined cohort of people with this disease. That's what drug companies really like. They want to know a lot of information about the patients, and if you already have that, it puts you in a good position to try and get clinical trials started.
Okay, well, thanks ever so much for coming today and telling us about this.